Welcome to the Modern Patient Experience, a show about how U.S. healthcare is adapting to new patient expectations. I'm James Furbush, Director of Marketing at Access One, a company that empowers revenue cycle teams to help all patients effortlessly pay for care in full or over time. In each episode of this show, I interview executives from hospitals and health systems, physicians and nurse leaders, digital health pioneers, and others to better understand what it means to be truly patient-centric. The goal is to serve up new ideas, frameworks, and tactics that will help your organization give your patients the best clinical, financial, and operational experience. And away we go. Hi, welcome back to this week's episode of the Modern Patient Experience with your host, James Furbush. My guest this week is Dr. Josh Israel. He is the Senior Medical Director of Quality and Wellness for Aledade, and very excited to have him on. We're going to kind of dive into behavioral health and sort of get a lay of the land. Josh, welcome to the show. Thanks so much for joining us.
Thank you, James. Glad to be here with you.
Yeah, so Josh, I'd love for you, if you could, just to provide people a quick overview of sort of what your role at Aledade is. And for those who don't know who Aledade is, if you can kind of just give a quick primer on the organization and sort of what you're up to in the healthcare delivery space.
Sure. So Aledade is a company that helps physicians start and run accountable care organizations. Accountable care organizations, it's a tucked away piece primarily implemented as a result of Obamacare. And the gist of it is trying to help the healthcare system reorient from just sick care to changing the system so that physicians get paid more for keeping their patients healthy than they otherwise would have for taking care of them when they get sick, which is how the current healthcare system is structured in this country. So Aledade helps physicians join these essentially virtual groups or accountable care organizations and then run them to the benefit of the physicians and to the health of their patients.
That's awesome. And so physician-led, not because most ACOs I think are like hospital directed, but this is mostly aimed at sort of physician-led ACOs?
It's entirely physician-led ACO, and we feel pretty strongly that's the way to get change in the system, that when you talk in this country about lowering care costs, one of the main targets is reduce hospitalizations and emergency room visits, which you get by keeping people healthy so they don't need to go there in the first place. If you're a hospital-based ACO, you may make a little bit of money by keeping your patients healthy through the accountable care program, but you're probably going to lose more in revenue from the patients who don't come into your hospital or don't come into your emergency room. Independent PCPs don't have any dual allegiance like this. If they keep their patients healthy, there's no downside to them financially. So it's really just a win-win for the patients and the physicians. And right now, if people aren't getting sick as much, they're not going to the hospital as much. And so that is in some ways where the money comes out of.
Yeah, that's awesome. And so then your role as the Senior Medical Director, Quality and Wellness, so what do you sort of oversee? Because you're a psychiatrist by training, correct?
I am a psychiatrist, and we'll talk about that some.
Yeah.
This particular role, work on quality and wellness, doesn't have a lot to do with that. Part of being an accountable care organization is it's not enough to just save the healthcare system money. There's lots of ways you can do that don't benefit the patient. So you want to show that you kept your patients healthy in the process of saving money. And one of the ways that payers, what we'd call insurance plans or for Medicare, the government, one of the ways they keep track of patients not just getting stinted on care is quality measures. So making sure, for example, that all the patients have had mammograms or colonoscopies or had their blood pressure checked. So you don't want people encouraged to save money for the healthcare system by encouraging people not to stay healthy. And one of the ways you do that is various quality measures. So part of my role is keeping an eye on those metrics.
Got it. Okay. That's great. Thanks for that context. Your kind of role as a psychiatrist, good insight into sort of behavioral health. It's one of those topics that I feel like is, I don't know if this is the right way to express it, but it feels like it's one of those sort of like buzzy topics, right? Like people, whether it's like VC money getting thrown at behavioral health companies and things like that. But I wanted to have you on to talk to you about, because I feel like, I'd love to have you paint a picture for what that experience is currently like for most patients sort of navigating behavioral health needs.
Yeah, in a word, the patient experience is terrible. As you mentioned, mental health can be a buzzy topic, or behavioral health, depending who's defining it.
Yeah.
But there's been a lot more talk than there is progress. It's really not a good system. If you are a patient with a behavioral health problem, it's almost hard to design a worse system. There's a huge shortage overall of behavioral health providers. So it starts with that. And then even within that, those providers who are out there, many of them have found that they can opt out of taking insurance. So there's even fewer available for patients who are trying to get healthcare with their own health insurance that they've essentially already paid for, often through their employer. If you are somebody with depression, for example, it's just very hard to find somebody to help you. Depression, as we know, especially in more severe forms, often comes with hopelessness. So somebody may already be feeling doubtful that mental health treatment will even help. So it doesn't take a lot to put barriers in front of them to dissuade them from reaching out for care. And then the system goes and does exactly that. They may call one or two people, they don't get a call back. If they are extra motivated, they may contact their insurance provider and get a list of 20 people and call them all, say, are you taking my insurance? A lot of time they won't get any calls back, or they may get a call back saying, I can see you in 3 months. It's not a great system, and people will often give up and not go get help.
And so I'm curious, so how come the not taking insurance, is it like they just take cash payments? Why is that something that is sort of a prevalent among providers and professionals in this space?
The answer probably, as it is to many things, the answer probably is simply money. You can often make more as a psychiatrist by not taking insurance than you can with it. Or even if the reimbursement were the same, there's less paperwork, you have more control over your schedule. And somewhere along the line, it started that there were enough people opting out that then almost everybody could opt out. Because if you were a psychiatrist in a city and most of the others had opted out of insurance, then you can too, and people will still have to come to you. It is something that people are often willing to pay out of pocket for. So that's some of it as well. It's something that people feel, they know they're upset, they know they're not doing well, so they may be more willing to pay for it. But I think at this point, it's simply a matter of once the snowball got rolling and there weren't enough behavioral health providers and there were lots of people doing cash only practices, that it became easier and easier for people to opt out. At this point, until psychiatrists can make more money than they're currently doing now, and with fewer administrative hassles, it's going to be very hard to lure them back into the network.
Yeah. And have there been changes? Have you seen it sort of like in the insurance design? So I would think if they're opting out, has there been that flip side of insurance, payers redesigning how they provide and reimburse for, mental health and behavioral health services as a result, or are they just not?
There are many ongoing attempts to redesign the system, but I'm not aware of any that directly will reimburse better. And I think that's where we've been stuck for a number of years now.
Yeah, it's almost like I've heard this too with like case management, where there's reimbursement for it, but it's not nearly enough to make it like the covering the cost of doing the program and having case management, and that the reimbursement for it actually isn't enough to make that investment worthwhile, which is unfortunate because at the end of the day, it's the patients who suffer, right, from that sort of lack of alignment on this. So it's not a good place. And so it sounds, healthcare, we're just like not meeting the needs for patients who need these services.
I would say that's very much correct. Patients and their families who are caring for them or living with them really do end up with actual suffering as a result of it.
Yeah. So do you have a sense of the consequences sort of how the system has formed? Do we more patients in the emergency room? What are some of the sort of downsides of how this, how we are essentially failing these patients?
Yeah, we know that there's more absenteeism from work as a result of behavioral health disorders that go untreated. There's a phrase called presenteeism, which is people who still show up at work but just aren't doing very well because they're depressed or anxious or in any other way struggling with mental health disorders. We know that medical care gets worse for patients who are suffering, for example, from depression. People are just less likely to take their medications, less likely to follow up properly. So there are a lot of consequences to it. The biggest one, though, really is just hard to define and quantify, which is just people suffering, people being unhappy. And it's sort of hard to put a dollar value on that, but there's just an awful lot of that.
Yeah. I mean, so the big question is then what needs to change? How do we design a better system that can actually better meet the needs and serve the needs of these patients who, need help and need to be better taken care of?
Yeah, the first part, as we've sort of covered already, would be higher reimbursement rates. And that wouldn't fix things overnight. If you suddenly paid double, people right now have full practices, they have lives that they like and enjoy. and you need people to become psychiatrists. So that training pipeline needs to expand. And that's not something that happens very quickly, but that would certainly be the start. And this is not unique to psychiatry. Most of the specialties that involve talking a lot with patients, that involve solving cognitive puzzles rather than doing procedures, are underpaid relative to the procedure based specialties. So orthopedics or cardiology. It's a system that evolved for a number of historical reasons, but that's the one we have now, where if you do things physically, if you have machines and procedures, you're going to get paid a lot more. As a result, in medical school, when people are matching into residency, the on-demand specialties, the high-demand specialties, the ones that are hardest to get into, that are most overcrowded, tend to be those that are procedure-based and reimburse the highest. I don't fault people for going into those fields at all. If you're an orthopedist or a cardiologist, you're helping people. You can go home satisfied at the end of your day that you have done good and helped people in the world. So it's not anything about the people choosing those specialties. It's on us as a system, as a society, to recalibrate. If we want more primary care, if we want more pediatricians, geriatricians, and psychiatrists, we really do need to recalibrate the system around better reimbursement for different specialties.
Yeah, that makes total sense. It's sort of like the age old, if you want more people to go into, say, teaching, you have to pay them like you would any other high trained, highly educated profession. That's interesting. And, how can we because it's a little bit that intersection of, there's the role of like providers, payers, technology. How do you sort of see sort of those areas that are aligning to sort of, because it's one thing, right? It's like payers can provide, they can do their role where they can pay, reimburse better. Then there still might be a pipeline issue where people are still not going into that field, for instance. But do you have a sense of how sort of those three areas can sort of better align themselves to sort of provide a better experience for these patients? That's kind of a meaty.
Yeah, what were the three things? I got technology. What were the other two?
Payers, and then like provider orgs, so large healthcare systems or just, provider groups in general.
Okay, so I may have to answer those separately. Technology, at this point, I don't see any easy technological fix. There's certainly people out there selling mental health apps. I have very little hope that those are going to make a substantial difference in the availability or success rates of behavioral health treatment. There is telehealth, obviously being able to access patients via computer. And this can be helpful in shortage areas where there's just nobody around. If you're in a rural part of the country, it is a potential solution. Right now, though, given that there's an overall shortage, if you fix the shortage in any given area, you've created it in a new one, right? So there aren't even enough behavioral health providers in urban areas. So if we use telehealth to now provide it to rural areas, there's an even bigger shortage in the urban areas. So the technology can't solve just a fundamental supply problem. As far as healthcare systems, I do think healthcare systems are reasonably well positioned to address it. If you have a system like Kaiser or the Veterans Hospital, they do provide pretty good care for their patients, even their behavioral healthcare patients. What you have right now in the country is a not bad social safety net system. So if you are getting your care at a community health center or at a county hospital, the Medicaid system, there often is behavioral health services available to you. So that's at that sort of bottom end of the safety net, for lack of a better word, the social safety net does provide some care for the patients with very severe mental illness, bipolar disorder, schizophrenia. It's not ideal, but it's there. It can work. And then at the high end, you have people who can pay a lot of money out of pocket and they get care too. It's the sort of vast middle where it's much harder to find help. But if you have a system like Kaiser or the VA, where they are responsible for the full cost of the patient's care, they're aware that behavioral health matters and that costs matter because the costs come back to them. And they have done a decent job making sure that they are appropriately staffed up. The other place actually that you actually see a lot of mental health care, I used to live and practice in California, and the behavioral health services in prisons were terrible. And it ended up that there was a court order that they had to pay better the court order was they had to provide more mental health treatment in the California prison systems than they were doing at the time. They just simply had to. And they basically had to up their pay scale so that right now, one of the best paying behavioral health jobs in California is for the prison system. Even there, they still have a hard time recruiting because those are not easy jobs. But when it matters to the healthcare system, they can do a lot to solve it.
I mean, that is so fascinating to me. So this was chloride count, like from a,
Yeah, I believe it might even be a consent decree is what it's called.
okay,
We might want to fact check it before you go
sure.
on air, but there was some sort of court mandate that they had to be providing more behavioral health treatment in the prisons than they were doing at the time. And really the only way they could accomplish that was by reimbursing much higher than the community standard.
Yeah, to encourage people to come, professionals to come into the system to provide care. That is, I'll look into that because that is totally fascinating to me. This is great. So you're not sort of bullish, other than telehealth potentially, but some of the sort of fancy digital apps that people are talking about, you're not too bullish on that. Is there a reason for that? Is it just you don't think? I don't know. I'm just kind of curious. I was surprised that you are so bullish on that, but is there a reason for that?
First of all, think about all the apps that you have downloaded that you haven't used on your phone, that you're well intentioned to use. How many meditation apps does each person I know have on their phone that they intend to start using next week? Let alone all the media apps. That's just the fate of an app, right?
I probably use 10% of the apps on my phone that I have. It's just digital clutter at this point in some ways.
Yeah, the stats bear that out, that most apps don't get used. So there's just starting from that fact. Then behavioral health is complicated. It's just not cookie cutter. It often requires a personal touch. Often part of the disease itself is lack of motivation, lack of ability to stick to things even that are good for you. Sometimes we can get into the sort of psychology of why people don't treat themselves better, but there's a lot of it there. And
Yeah.
mental health apps that are just sort of sitting on your phone, I just don't think they're going to crack it. And I've been now in the health tech space long enough. This was my theory when I started, and I just haven't seen one take off at all. And I don't expect that we will.
Yeah, because it sounds like it requires maybe more of the patient than they could potentially give.
I think that's the case in some cases, certainly. But then in other cases, it's just hard. Depression is not easy to treat. There are a lot of factors that go into causing it. It would be nice if something as simple as an app made a difference. I just don't think we're going to see that work at scale.
Yeah. How much I'd love to kind of jump back. I know you said the barriers to getting care can be quite difficult. And it sounds like the unintended consequence of sort of the reimbursement structure for it is one of those barriers. Are there other barriers that you've seen that sort of add friction and sort of get in the way of patients being able to get the care that they need?
Sure, there's certainly stigma. People can feel a lot of shame around mental health. It's really unfortunate. It's bad enough to feel depressed than to feel like you have something wrong with you, some sort of moral failing to be that way in the first place. There can be physician challenges as well. Some physicians aren't comfortable with the topic. Maybe they don't have time. Maybe they just don't feel like they have the skills. It wasn't part of their training in any intensive way. So they may not know how to make that referral or be comfortable talking about it. But certainly you have some patients who just feel like they shouldn't need to get this care, or getting the care would mean that they are in some ways weak or something unfortunate like that. And then even once people do get into care, it's still not always easy. We are not great as a field at choosing the precise right treatment for the right patient. Therapy, for example, there's all kinds of modalities of psychotherapy, cognitive behavioral, psychodynamic, trauma focused, and it's not always clear which one will help the patient. The good news there is that the primary finding in therapy is that a provider who listens to you and cares about you is the essential ingredient more so than the specific therapeutic modality that they're using. But it's not always easy to line up the right patient with the right treatment for therapy, and then even more so for medications. We don't have a great way of knowing which pill will work for which person right away. It often involves trying 2, 3, 4 medications for depression, for example, to get the right one. You may find benefit but have side effects and need to readjust then. We find that somewhere around 15 to 20% of patients, even with every possible treatment, their depression is still not going to get to remission. And then you can require some more complex treatments, electroconvulsive therapy, ketamine treatment, transcranial magnetic stimulation, all of which are a little hard to come by. Not a lot of availability around those. But so it's really can be hard for patients. They get through this gauntlet of trying to find a provider. They sometimes feel like, okay, fine, I'll take a medicine. I made it here. I don't really want to take a medicine, but I'll do it. And then it doesn't work. Or maybe they have a side effect that they don't like. Sexual dysfunction is the number one side effect of a lot of the antidepressants. That's the last thing a lot of people want to have happen to them. And maybe they're embarrassed to bring it up if it does happen. So they just stop the pill or they stop coming in for treatment. I know that when I do treat patients for depression, I start right from the get-go saying, you should know the first pill may or may not work. You ought to mentally be signing up for 2 or 3 medications before you even consider giving up on this. I might not say giving up on this, before you draw any conclusions about medications around this. My glib analogy is I'll say, somebody may come in, for example, and say, I tried Zoloft, it didn't work for me. So I don't think antidepressants work. And I say, if you tried apples and you didn't like them, it doesn't mean you should draw any conclusions about how you feel about fruit. There may be a more
Yeah.
sophisticated analogy, but that's what I tell patients. And it's true. So it's not easy. The whole system can be a hard one for people who are depressed. Maybe by the time they finally go get treatment, they're really at the breaking point. And then you have to tell them, I'm not sure this one will work. And even if it does, it's going to take sort of 3 to 6 weeks to work. It's not easy.
Is there also a challenge around like adherence? Like maybe like my own behavior where, and certainly not comparing to like mental health treatment. If you're on a regular regimen and you start to feel better and you're like, oh, my whatever is better. I don't need to like if my allergies, if all of a sudden like my allergies are gone, I stop taking my allergy medicine and then they get worse. And it's like this weird mental thing where like you think you're better and the thing that's making you better, you feel like you can stop taking it just because you've gotten better, but you still need to take it to continue to be better. Is that a challenge as well? I don't know if I'm expressing that eloquently enough, but I would imagine that's a challenge too.
I think I understand what you're saying. Yeah, it's a challenge with behavioral health disorders. It's a challenge with all medications.
Yeah.
Even people with type 1 diabetes don't always take their insulin, even though there's, no more clear example of a medicine that's necessary and beneficial. People don't like taking medicines, or maybe their lives are busy and they have more going on than they have the bandwidth to manage, and the medication falls away. They may have trouble filling it. They may have to have a work schedule where it's hard to get to the pharmacy. So all kinds of things come up for people in the course of taking any medications. I think particularly for behavioral health disorders, where for most patients, the last thing in the world they want to be doing is seeing a psychiatrist or taking a psychiatric medication. And so the minute they feel better, they're going to try to get off this thing. And yeah, we certainly do see that. The general recommendation is to take an antidepressant for at least 6 months past the time where you have achieved remission. And we do tend to see a pretty high relapse rate for people who stop sooner than that. But we do know that people stop taking their medicines. And many people, they get the prescription filled, they take it for a week or two, and they just don't like it. They don't like being on psychiatric medicine. It just represents something to them that doesn't sit well with them. And any reason that doesn't take much to get them to stop taking the pill.
Nice. So Josh, so what are the three, reimbursement, changing that, what are some like two other changes that you would like to see to make this system better for patients?
I do think the more we could integrate behavioral health treatment into primary care, the better off the system will be. Certainly, as we've said, many people don't like going to see a behavioral health provider, but many more people are comfortable seeing their primary care physician. And so if you could just have a setup where the psychiatrist was literally in the office down the hall from the PCP, and the primary care physician could say, you seem like you're depressed. I see that you're struggling. Let me just introduce you to my colleague. That is probably going to go a whole lot better than handing the patient a list of phone numbers. So that's certainly one thing. There are care models. They have various names: integrated behavioral health, collaborative care, where even if the behavioral health specialist, whether it's a psychiatrist or a therapist, are not in the office with the primary care provider, they're a phone call away or a video away. And you could just connect a patient directly from the PCP's office. I think that would help. Even if we could improve the supply issue, just getting more integrated networks of referrals. So it wasn't the patient having to call around, but the PCP could push a button, send a referral, and the patient would get a call. We have worked with some vendors who provide that service, and even then the patient doesn't always return the call. They may have been comfortable telling their PCP they were depressed, but don't want to talk to what they perceive as a strange psychiatrist or therapist about this topic. So the more we could integrate it, but that is also just part of making the experience better for patients. The lack of integration, it just makes a situation that's already hard for patients that much harder. So the more it could be a seamless transition from something they're already doing and using, which is getting primary care, into the care of a behavioral health team.
Oh, that's awesome. That's so great. This has been a really fascinating conversation. I appreciate you making the time. One final question before I let you go. Where do you go to sort of find new ideas and fresh inspiration?
Sure. On this topic, I would say capitalism does well for generating new ideas. I've sort of maybe put a negative spin on it in the way that it has sort of over indexed us on specialty and procedural care versus primary care and psychiatry. But it also generates a lot of ideas. There is money to be made if somebody can crack the nut of better behavioral health care. And so there are people trying new ideas. There are startups trying to solve this. And I see people out there working to solve this. And I think that's a good thing. So in many ways, a company like ours, Aledade, is big enough now that you just have to let people know you work for Aledade, and people will come to you with their ideas that they're working on and trying to pitch. And we've heard some great ideas. I hope some of them work out. And then more simply is, you go to conferences, you keep up with the medical journals. There's a lot of people thinking about this space. A lot of people are touched by behavioral health disorders, by mental illness. A lot of families have somebody suffering from this. And so there certainly are a lot of people thinking about this and trying to improve the system. So you just have to keep your ears open, and there are a lot of good ideas coming around.
That's awesome. Do you have an example of one or two ideas that you've heard that do sound promising to you?
Yeah, right now it is about trying to make networks. This is not such a great innovative idea, but right now the system is just very scattered. And so behavioral health providers are often just a siloed primary care practice. So there are people trying to create sort of networked systems where there would just be one phone call, one button push, and trying to incentivize providers to come into that system, trying to make it either just a especially nice place to work, or maybe as a system you're taking any administrative burden off the therapist and psychiatrist so they'd want to join. Sometimes it's luring people in with the promise of, you have a startup, we're not going to be able to reimburse you higher than insurance does, but we'll give you some stock options. So come join our behavioral health company. And there are some groups out there that are succeeding in creating networks, and we're hoping to link up with some.
That's awesome. Dr. Israel, thank you so much for joining the show this week. And I really appreciate your insights into this topic, which I think is definitely an important one for people to hear about. So thanks so much for sharing your knowledge.
You're welcome.